Welcome to this complete guide on dehydration, a critical fluid and electrolyte imbalance in children, essential for your nursing exam preparation. Dehydration is a condition where the body loses more fluid than it takes in. Children are more susceptible due to their higher proportion of total body water and higher metabolic rate. Next, we will review the various types of dehydration. The most common causes are gastrointestinal issues like diarrhea and vomiting. Other causes include diabetic ketoacidosis, burns, heat stroke, and fever due to increased insensible loss. Key history points for assessment include evaluating fluid intake and output, checking for urine passage in the last 6 hours, observing the child's activity level, and noting their thirst. The skin pinch test, or skin turgor, is performed by pinching the skin of the abdomen. If the skin goes back quickly, there is no dehydration. If it returns slowly, there is some dehydration, and very slowly indicates severe dehydration. Sunken anterior fontanelle is a significant sign of dehydration. Fluid loss decreases intracranial pressure, causing the soft spot on the baby's head to sink or depress. The IMNCI, or WHO classification system, is used to assess and manage dehydration. Let's cover some rapid-fire one-liners. The best indicator of dehydration in an infant is percentage weight loss. Doughy skin is seen in hypertonic dehydration, and the skin pinch test is performed on the abdomen. Dehydration is classified by percentage weight loss. Mild is less than 5%, moderate is 5 to 10%, and severe is over 10% weight loss. Management goals involve replacing lost fluid and electrolytes. Oral rehydration therapy is the first line for mild to moderate cases. IV therapy is reserved for severe dehydration or shock, and zinc supplementation is also recommended. Plan A focuses on preventing dehydration at home. The 4 rules include giving extra fluids, continuing feeding, zinc supplementation for 14 days, and knowing when to return to the clinic. Plan B, for some dehydration, involves oral rehydration therapy using WHOORS, administered at 75 milliliters per kilogram over 4 hours. Monitoring and reassessment are key. Plan C is an emergency requiring IV fluids. The fluid of choice is Ringer lactate, with normal saline as the second option. The total volume is 100 milliliters per kilogram. Never use dextrose for resuscitation. The video shows the Plan C schedule for administering 100 milliliters per kilogram of fluid. For IV access, aim to establish it quickly. If peripheral access fails, use the intraosseous route. Immediately start a fluid bolus of 20 milliliters per kilogram for shock. This scene displays the composition of the new WHOORS. The rationale for ORS components includes coupled transport of glucose and sodium, citrate to correct metabolic acidosis, potassium to replace losses, and reduced osmolarity to lessen vomiting and stool volume. To prepare ORS, wash hands, measure 1 liter of clean water, pour the entire packet, and stir. Use the solution within 24 hours and do not add sugar, milk, or juice. The correct answer for the osmolarity of the new WHOORS is 245 mmosm/L, which helps reduce the need for IV fluids and stool output. The concentration of sodium in the new WHOORS is 75 mmol/L, reduced to prevent hypernatremia and match the glucose load. According to IMNCI, a child with sunken eyes and restlessness or irritability is classified as having some dehydration, corresponding to the yellow column. The fluid of choice for treating severe dehydration or shock is Ringer lactate, as it best mimics plasma electrolytes and helps correct acidosis. Maintenance fluid calculation follows the 100-50-20 rule, based on the child's weight in kilograms. Hypovolemic shock signs include cold skin, tachycardia, and delayed capillary refill time. Management requires a rapid IV bolus of 20 milliliters per kilogram, which can be repeated up to 3 times. Electrolyte imbalances include hypokalemia, resulting in muscle weakness, and metabolic acidosis, characterized by deep, rapid breathing. To quickly review, the shelf life of prepared ORS is 24 hours. The best non-shock route is oral. Citrate prevents metabolic acidosis, and glucose facilitates sodium absorption. Common nursing diagnoses relate to fluid volume deficit, risk for electrolyte imbalance, impaired skin integrity, and deficient parental knowledge. Golden points to remember include the recipe for homemade ORS, zinc dosage, severe dehydration signs, and the 20 milliliters per kilogram bolus dose. In summary, assess the child for danger signs and classify dehydration. Treat with Plan B for some dehydration or Plan C for severe cases, and focus on prevention with zinc, hygiene, and continued feeding. Thank you for watching this video. All the best for your exam.